You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello everyone, welcome back to the Just Medicine podcast. My name is Annie and I'm currently a medical student at UBC. So I recently got involved with this podcast and I'll be recording a handful more episodes into next year, so you will be hearing some more from me. In today's episode specifically, it's the first episode of a multi-part series that I'm planning on recording with different guest speakers under the broad topic of health equity with regards to women's health in particular. So this will be a 3 to 5 part series, and in each episode we'll take a specific topic regarding women's health and dig into the relevant information on those topics specific to Canada and the Canadian healthcare system, so both you and I can learn more about the current barriers to equitable care and how healthcare workers can strive to provide care in a patient-centered and individualized way. So today we'll be talking about access to contraceptives in Canada, along with both barriers and facilitators to providing equitable care in that realm. Although we have a lot to be grateful for with regards to Canada's healthcare system, there are still many gaps and issues that need to be addressed. So although Canada has universal healthcare, we don't have universal access to contraception, and that varies a lot even from province to province, and there are many complex factors at play. But before we get into all of that, I am very excited to introduce today's expert guest speaker. So on the podcast today, we have Dr. Yuyang Wang. So Dr. Wang is an adjunct assistant professor with the Department of Obstetrics and Gynaecology at Queen's University, where he is currently practicing at Brockville General Hospital. Dr. Wang completed his medical schooling at the University of Western Ontario, and then his residency in OBGYN at Dalhousie University. He completed his fellowship training afterwards in contraception advice, research, and education at Queen's University, specializing in complex contraception management, transgender health, and pediatric and adolescent gynecology. And when not practicing medicine, he enjoys spending time with his partner and dogs and touring the country on his motorcycle. I had such a great conversation with Dr. Wang. He has so much to share, so much experience, and points out some really interesting nuances that you might not consider off the top of your head. So I hope you enjoy this episode as much as I enjoyed recording it, and let's get into it. Hi Yang, thank you so much for taking the time to chat today.
Oh, thanks you for having me, Annie.
Yeah, of course. I'm excited for this conversation. So just to start, sort of out of personal interest, I'm just curious why you chose OB-GYN and what that decision process was like for you and what led you further to do your fellowship in contraception.
Yeah, so I kind of fell into the specialty by accident. A lot of my research and involvements in medical school was with emergency medicine and trauma and general surgery, etc. But I had this opportunity after second year of medical school to do an elective with one of my small group's preceptors, and she was one of the generalists at Western, and it kind of just blew my mind, the scope of care that I didn't really appreciate when coming into medical school, what obstetrics and gynecology was. But the classic is always getting to deliver babies and doing surgery, and that's true. But it was sort of the scope from beginning all the way to the end: cancer care, pre-cancer screening, antenatal care. So it was very much encompassing. But ultimately, what pushed me over the edge was really this social justice component that was present in the field, because at that time there were still huge gaps in access to things like contraception care, abortion care within regionally and nationally as well. And the advancements that these dedicated providers have made over many, many years, and how passionate they are to ensuring equity and quality of care and access throughout the country for all women was just really sort of blew my mind. And that ultimately is what continued forward during my residency, and ultimately led me to doing research in LGBTQ medical care, and then subsequently into this contraception care, where the focus is about research and education and advancement of education around contraception and also access as well.
That's great. Thank you so much for sharing. I'm really interested to talk to you now with all of that experience. I have a lot of questions today. I'm also curious with your fellowship specifically, how that has guided your everyday practice or even changed your perspective on things in OB/GYN.
So yeah, the fellowship is the Contraception Advice Research and Education Fellowship as part of the Queen's OBGYN program. It's one of two family planning fellowships in Canada, the other one being the focus on advanced termination care as run through University of British Columbia. The fellowship in itself is an emphasis on advice, research, and education, but there was also components in pediatric and adolescent gynecology, transgender health as well. So it really changed my ability from as a general practitioner, where I can open up the scope of care that I can offer to all patients, including those in my minority populations as well. And also it gave me the ability and access to be able to educate those in the community, whether it be family practitioners, nurse practitioners, and become involved in education locally to make this type of care more readily accessible at all levels.
Mm-hmm. Mm-hmm. That's really cool. Honestly, kudos to you. I think it's a really important thing. And it's great that some advances are being made, but there's obviously still so many gaps and things to chat about today. So before we get into the issues or the barriers with regards to practicing equitably in terms of contraceptive access and prescribing, and all of that, I was wondering if you could give us just a brief overview regarding the options of contraceptives in Canada, what the differences are, assuming the listener doesn't know anything about the topic.
Sure. In terms of various options available in Canada, this is by no means a ranking, but from least reliable to most reliable options. Number one is going to be natural family method, which we encompass in terms of timed intercourse, withdrawal methods, basal body temperature monitoring. The reliability is terrible, so I usually advise most patients, unless pregnancy is something that they want, or they are willing to accept as a consequence, then definitely it should be avoided. Usually when we talk about contraception, there's two big questions we always ask the patients. If you were to get pregnant, how likely are you to maintain this pregnancy? And secondly, it's going to be how important is it for you to not be pregnant? Is this the absolute number one goal, or is it more if it happens, it happens kind of situation? So those really would help guide us in terms of how much a patient wants to avoid being pregnant. So going down the line again, alternative options would be combined hormone contraception, which includes things like the classic oral contraceptive pill. There's also the transdermal patch. There is a transvaginal ring. Then moving forward, there are the progesterone-only options, which also includes a oral contraceptive. Then there is the Depo-Provera progesterone-only shot. And then we move on to the devices. So the most prominent one is the IUD. It comes in two varieties, a hormonal and a non-hormonal one. They're both great for contraception, but in terms of differences, they do provide alternative benefits between the two systems. And then lastly, the newest kid on the block over the last 2-3 years is the subdermal implant, which is also progesterone only. And that's the newest player on the block, although it has been available in the UK, Australia, and USA for decades. It's new for us, and it is considered one of the most reliable options. And then very, very, very lastly, you're looking at surgical contraception, which would be either tubal ligation or self-injecting, where we just remove the tubes entirely. Mm-hmm. I guess I forgot to mention condoms is always going to be, or Berry method is choice of contraceptive choice available in Canada. And I forgot to talk about that one.
Right. Okay. Thank you. That was a really great overview. I can see how it might be overwhelming for patients deciding between so many options at times. And I know you said that one of the main questions to ask is how the patient might feel about becoming pregnant. Aside from that, I was wondering if there are main trends or factors that you would say sway decisions in terms of choice of contraceptive options.
Right. So, especially over the last few years, social media is going to be huge, both with a variety of options available. Instagram, TikTok, Facebook, etc. So social media has really altered people's perceptions, both for the better and for the worse in terms of the contraceptive options. In Canada as a whole, the oral contraceptive pill is still the most prevalent used. I think latest data shows it's about 60-70% of the population that uses a contraception uses oral contraception.
Wow, okay.
But the one that's gaining more popularity is the devices, mainly around the IUD. I think currently they're sitting roughly around the 10% mark, which has been a steep increase over the last decade, but it still has room to grow as well, because I think at the end of the day, that is our, from a contraception standpoint, the longest acting with the lowest maintenance is always going to be the best option available. So there's still room to improve in terms of access to long-term, long-acting reversible contraception.
Right, for sure. My follow-up was just going to be why people might opt for an IUD over something like the pill. Would you say that it tends to just be that it's in and it's done and you don't have to worry about it, you don't have to take a pill every day, or what would you say the main pros to having, say, a hormonal IUD over the hormonal pill would be?
Yeah. So let's start with the pill. The pill, from a pro's perspective, it's simple, it's straightforward, right? You take it once a day, and you can take it with the sugar pill. You don't have to take the sugar pill. You can skip on to your next pack. Onset of contraception, we always usually say a week, and then if you don't like it, you just stop it and wash this out from your system very, very, very quickly. There's no needing to, in some parts of Canada and the world, you actually don't need to see a physician to get the oral contraceptive pill, right? So you have easy access available, and if you don't like it, you don't have to go see a physician again to get it taken out. So that would be the pro. The con is going to be its user reliability. So that's always the big thing. You have to be able to take it every day. You have to remember what to do in case you miss 1, 2, 3 tablets, depending on where you are on your packet. And that because of this maintenance, there's always a, when we talk about contraception, perfect use and typical use. So typical use for ones that require more user maintenance has a a higher rate of failure versus perfect use, right? In terms of the hormonal IUD, it's great, especially with the recent news. The Mirena IUD previously was marketed for 5 years for contraception. In Canada now, it's actually labeled for 7 years. In the US, it's actually labeled for 8 years. So you can see why this is a big draw for people who want something long-term and reliable, is that it's inserted and then you're good to go from a contraception perspective for as long as you want over the next 7, 8 years. But the downside to it is it is an invasive procedure, and which can be quite traumatic for those who never had any sort of examination before, who has severe anxiety regarding healthcare and medical procedures, who've had previous trauma, who had previous poor experiences with any sort of medical invasive examinations, right? And also it's quite painful. It's the degree to which people tolerate it is quite vast, but at the end of the day, it's still a very uncomfortable procedure. And if you don't like it, you actually need to go back and undergo another invasive examination to get it removed. The plus side is, though, if you do like it, you have long-term reliable contraception that you have control over. And it's also for a certain set of population, it's hidden. Their partners may not be able to know it, right? It's something that they can conceal, and which is not something that a lot of people consider. That you don't have to disclose it, and it is something within your own control. The other benefit from hormonal IUD would be decrease in menstrual bleeding, depending on which of the two hormonal IUDs you use. And the one with more hormones, the Mirena IUD, actually is indicated for treatment of heavy menstrual bleeding as well. So a high percentage of patients actually don't get a period with it, and that benefit can be for many, many years, right? So those are some of the big positives that comes with the hormonal IUD.
Right. A lot of interesting considerations there. I hadn't thought about the potential of concealing contraception. I'm sure there's a lot to talk about when you're deciding with a patient which option to go with.
Yeah, and not everything is very obvious to mind, right? You have to consider patients as a whole, their religious background, socioeconomic status, ability to access medication, right? If they don't have private drug insurance, then depending on where you are in Canada, your ability to access certain types of contraception is quite limited.
Yeah. I think it's important to talk about cost and how coverage might vary between provinces. Although Canada is a country with universal healthcare, we don't have universal access to contraception. And I believe we're actually one of the only countries that satisfies that criteria. So I was wondering if you could talk a little bit about contraception coverage in Ontario, what's covered by like the public health plan. I looked into that a bit and I saw that it might depend on age,
Mhm.
whether you have a private plan or not. So I was just wondering if you could elaborate on that and how it impacts access.
Yeah, so Canada is very much one of the worst in terms of access from a public health standpoint of contraception, as opposed to somewhere like France. It's free for all ages, right? In terms of in terms of Ontario provincial access, yeah, everybody under the 25 gets free contraception. And that's a sweeping statement. The only ones that don't include is actually the patch, the Ever patch, which is good for a
Mm.
week at a time. But and the non-hormonal or the copper IUDs, those are not included. The hormonal IUDs are included, so as well as the implant and all the other options available. So in terms of access, it's fantastic if you are 25 and younger.
Hmm.
But for anybody older, which is still a humongous part of the population, then it becomes very lacking. Various public health units give out free contraception, mostly around condoms and also certain types of oral contraception. There is special access programs for those who are in the lowest socioeconomic situations in terms of access to things like the implant and the hormonal IUD. And we can always apply for special access or compassionate care programs to get certain types of contraception of types. But when you're 25 and older, it's more so the middle class, right? Those that
Hmm.
make too much but not enough and don't have private insurance, and that's kind of a big group that are the contraception, it can be lacking for them, and it's really challenging, right? And we give out as much free samples as we can, and try to supply patients in that regard. But that group is underserved in terms of their ability to access provincial contraception.
Right. Yeah, that's tricky with the age cutoff. What do you see generally happen then if someone is on a particular contraceptive prior to the age of 25 and then they turn 25, can't really afford the method they were on previously? I mean, they'd have to switch. Like, what do you see happen in your practice?
I actually have not encountered something like this yet. Most of the time, so personally, for those who are 25 and younger or who are about to reach that age, I strongly encourage them to consider something a bit longer acting, especially
Mm.
if they are if their plans for fertility is still a little bit far away and are truly trying to avoid being pregnant. But for those who are suddenly can't afford certain medications such, then it really relies on trying to gauge where they are on the social economic level. If they are meeting certain household incomes, they get free access to the implants and the other devices. But otherwise, we try to supplement through access through public health, where public health units can give out free contraception in terms of oral, and sometimes they have special access through the patch or the vaginal rings. But again, it's really through public health that they can access some certain types of contraception. And then most family physicians will stock samples and in these situations, and we readily hand them out for those who really need them.
Okay, so it sounds like you have some good methods to kind of accommodate the system with age cutoff, but from what I'm hearing, not ideal. Would be better if it was covered for those past the age 25. In BC, we've had recent changes. I'm sure you've heard about, I think it was as of April 2023, some research-informed decisions, actually. The BC government realized, I think out of some UBC research, the government was paying more to cover the medical costs of unintended pregnancies than it would be paying to cover free contraception for BC residents. And so the switch was made, and now under the Medical Service Plan, or MSP, the Public Health Plan for BC, contraception is covered. And I believe every form is covered, maybe not the brand name versions, but there's always a generic that you can get from the pharmacy, even the IUDs as well, hormonal implants, injections, the oral contraceptives, and as well emergency contraceptives. They're covered now in BC, which seems like a really great step in the right direction. I was curious if you think other provinces will follow BC's lead, or if not, what the barriers might be, because it sort of seems like a win-win situation to me for the government if they're saving money, not having to deal with as many unintended pregnancies, and then also the people living in Canada wouldn't have to deal with a cost barrier to contraception.
Yeah, it's a really interesting research you showed, because that's been well known for many years now. It's not new. It's reproducible globally that contraception from a cost savings perspective outweighs that of unintended pregnancies. And in fact, there has been recent research in Canada that shows that the majority of pregnancies, or a high proportion of pregnancies in Canada, are actually unintended. Right. So the data has been there, but the government has been slow to react, whether it be because of public perception, or in terms of what their money is going to, or in terms of maybe ideological differences. But that translation of research to actual legislation and access has been very slow, which again, it's still surprising again that the fact that women's health is still one of the last frontiers of change, because of the slow reversal of some of the patriarchal standards that we hold women to still. And that is sort of a reflection in the policies that are being made, the slow legislative change that's being made.
Right. That's really frustrating. The research is there, so you just, logically think that they would make the right decision or put that into action. But I'm sure as you mentioned, there are many factors at play. But here's hoping that the other provinces can follow BC's lead with time.
Yeah, I know that in Nova Scotia, there has been a push by the OB/GYN community to make contraception free in the province for all citizens, and that's been a push led by the Dalhousie Resident Society and the other medical society to advance this. Because again, it is such well known that from cost savings, it's a financial benefit for taxpayers, for the government.
So we've chatted about Ontario and BC. Obviously, that doesn't cover all of the provinces in Canada. But if you are interested in some stats for those that are listening, I found this really great resource. I don't know if you've heard of it, Yang, but it's the Global Contraceptive Policy Atlas. The 2023 version is out.
Oh no, I haven't heard of that one before.
So yeah, I'll send it to you. I'd love to hear what you think about it. I think it looks pretty good. So it's mapped out the countries of the world, and even in Canada, it's by province, considering a bunch of different factors like family planning counseling, online information on contraception, and public authorities' handling of contraceptive supplies. And they give percentage scores based on that information and recommendations for improvement just based on how well the countries or different areas within the countries are doing with regards to access to contraceptives. They took 185 countries and only 16 are ranked high on their rating scale for, as in like doing well with regards to access to contraceptives. Most countries are in the medium or very poor categories. And I know today's focus obviously isn't about global contraceptive access, but I just thought it's an interesting resource. And if you want to go take a look at it, you can see the Canada specifics too by province. They state that 46% of provinces provide financial coverage of contraception for all or most of their population. So again, unideal, less than half. So it seems like we could be doing a lot better. I really hope that we can make some advances moving forwards.
Yeah, for sure. And it kind of just highlights the disparity and inequality to access across the world, but more specifically across our country and also within our province, right? BC is a big province. I'm sure rural versus urban centers access is vastly different as well.
Yeah, of course. So I'd love to talk about that. So in terms of rural areas in Canada, it's very different. There's a lot of additional factors to consider aside from just costs. So even if you could afford a method of contraception, it doesn't guarantee that you'll have access to it. So how accessible are either healthcare providers or healthcare facilities when it comes to being able to access contraception in a rural area? You know, who are you going to get your prescription from? How are you going to get there? There's not always reliable transportation. Additionally, there's the factor of, really widespread healthcare facilities themselves, and there might not be a tertiary healthcare center or whatever the patient may need or want to access within the vicinity of where the patient lives. So that's kind of the first thing. I'd love for you to comment on that and the ability for patients to reach healthcare in terms of both healthcare professionals and facilities when they need it.
Yeah, so I think that's a very broad question in terms of rural versus urban center access to healthcare in general, because that's a very complicated question. In terms
Mhm.
of contraception access, I kind of in my head was breaking it down to access to preventing you from being pregnant, and also access to care for when you are pregnant. What are your pregnancy options? Because those two have even more disparity. So in terms of contraception, most rural individuals access to contraception is going to be the easiest is condoms, right? Access to some kind of non-natural family planning method would be condoms, and that's readily easily available. And then in terms of hormonal contraception, most family care providers, public health units, nurse practitioners are able to prescribe any type of hormonal contraception or contraception that's available. And then it becomes a little bit more limited. A patient wants a insertion device, whether it be implant or the IUD, then they need to go to a center or see specialists who are comfortable doing that. And that's not always available in the rural communities, where they sometimes have to be referred to a OBGYN because the family or nurse practitioners haven't done that much. So from my perspective, the more involved contraception that needs to happen, so whether it be through insertion or even surgical methods for contraception, the more options available for more urban patients, right? Versus those who are quite rural and needing to travel for an IUD, for an implant, or even for surgical contraception. This vastly is highlighted by access to abortion care or pregnancy options, and which I think is always relevant for talking about contraception. I trained in Halifax, and at the time of when I was training, Halifax was the only site in the Maritimes encompassing PEI where surgical termination was offered. So people as far as PEI will have to drive 3 hours down to Halifax to get their surgical termination, or to Moncton, which is 2 hours. Patients in Sydney, Cape Breton will have to drive 4 or 5 hours for the same, right? Again, this kind of highlights the more technical need of a contraception method, then the more a patient would need to expand their energy if the farther they are away from a more urban site.
Yeah, of course. So being able to access a healthcare provider to do a procedure like insert a device or anything like that is obviously a really important factor when it comes to deciding what type of contraception to go with. Another thing I wanted to ask you about was stock in pharmacies. So I read this anecdotal story where a patient in a rural area had discussed with their healthcare provider regarding contraceptive options, decided to go with the IUD or one of the IUDs, went to the pharmacy locally to pick up the IUD, and they were informed, sorry, we don't carry that. And then all of the nearby pharmacies were called and they also didn't carry that. So then the patient had to opt for another method that they wouldn't have preferred otherwise. I was wondering if you could comment on stock and how the
Yeah.
supplies are distributed.
That's correct, right? It's pharmacies are independent businesses, and every time they have to stock something, they have to purchase that and then subsequently turn it around to the patient. So if the demand isn't there for IEDs in certain areas, then the pharmacy, it's not worth it for the pharmacists to carry more than 1 or 2 of them because they have an expiry date and they're expensive to keep in stock. So the more urban centers definitely will stock more devices because the demand is there, especially the ones around universities, around sexual health clinics, around hospitals, etc. Right? Those are more rural, probably have a smaller patient, so it's not worth it or more costly for the pharmacist to stock it. That being said, a pharmacist may not be able to get you an IUD that day, but it is still something that they have to provide you. So sometimes then they will have to call it in, they have to have it shipped in, which can take a few days, right? So immediate access and rapid access is one thing versus access in general through pharmacy. Once you get to that level, then it is the pharmacist. From what I understand, their job to acquire you that medication, but rural sites obviously will have to take longer.
Right. Okay. So they have an obligation to order it or
Don't quote
get
me on
access to
that
it
one. You
somehow.
should, I feel like maybe that's my personal bias that it should be the
Yeah.
pharmacist's obligation to provide the medication that was prescribed. Right?
Would be nice. Yeah.
Yes. Whether or not that's true, I don't know, but I only hope for the best.
Yeah, of course, yeah. So, yeah, the rural conversation is tricky to pinpoint because I feel like there's so much at play. And what would you say is the biggest issue when it comes to rural access to contraceptives? Because I'd wondered if this stock thing was a really big thing, but if it's possible to order things, maybe that's not totally accurate. Would you say it's being able to access specialized healthcare providers for procedures, or what would you say is the biggest factor here?
I think just expertise in general,
Mm,
medical knowledge. So I think getting the device is one thing, but getting the information to the patient about all the options are different, right?
mm-hmm.
Family physicians, they do so much that they may not know it all. So there are certain things that nuances in terms of talking about contraception to patients and the various things that we do consider that may not be considered when patients are seeing their local family physician. And having then needing to go on to see a specialist can take long and cost a lot and travel, take time off work, etc. Right. So I think maybe it's more about the education available between rural and urban. That's a bit of a divide, and the time and effort it takes for urban patients versus rural patients to get access to more specialized care is also different as well. So I think that's one of the biggest hurdle is just more access to education, access to information, and where and how quickly and readily you can get to it. That's is a big hurdle for a lot of the rural patients, just because a lot of care providers aren't comfortable beyond the bread and butter. Not every patient is the classic high school, university age that needs birth control, right? Some have complex medical issues, high blood pressure, previous history of strokes, MS, who have accessibility issues, have LGBT considerations, right? How all those little nuances may push a lot of the primary care providers out of their comfort zone, so they had to refer it on, and then that's where a lot of the leg happens.
Right, that's really interesting. After your medical schooling, how prepared did you feel to talk to patients about contraceptives? And do you think that it's a curriculum issue? And if we worked on incorporating more regarding speaking to patients about contraceptives and all of those nuances you mentioned into our curriculums, do you think that would help
Right.
to address it? Or is that something you can just, harder to learn by the books more over time?
I think depending on schooling, you're asking depending on where I was in our schooling, right? After med
Mm-hmm.
school, how comfortable are you? After my residency in obstetrics and gynecology, how comfortable I am versus somebody who went through family training or general surgery or something else, right? And
Sure,
then
yeah.
subsequently, I did further fellowship in contraception.
Yeah,
So
yeah.
so in terms of it, I am still learning about contraception from my patients, from the educations that's there. It's ever evolving access to newer medications available. That is ever evolving, and even as somebody who has special training in this and special interest in this, I am still learning. So how much I caught up to what it is versus where I was at the end of medical school, it's leaps and bounds.
Mm-hmm,
It's
mm-hmm.
just because there's just so many things that, yeah, I did not consider, right? I didn't think about when talking about birth control. In terms of a curriculum, well, you are going through your first few years of medical school right now. How much has women's health outside of pregnancy, bleeding, so pathological issues, has there been? Has there been one talk about contraception? Has there been multiple talks about the social economic situation and social injustice that comes with women's health? Right? Because I think contraception involves all of that, the equity,
Mm-hmm,
the
mm-hmm.
equality, the history behind it, because that all shapes our understanding of what contraception is. And it's not just impacting, hey, it's not just you needing birth control. It is what that impact is on you, what that impact is on your health, what that impact is on your life. And I think from a medical education perspective, just like everything in medicine, there is always room to improve. So I think it is lacking because we are so narrow focused. Okay, your goal is to prevent you from getting pregnant, but what does that truly mean to each individual? That is different.
Yeah, I wish we had more time to dedicate to this in our curriculum, and maybe there's ways that we could shift it a little bit or a lot of it, and
Mhm.
teach medical students more about these other considerations and just things we maybe wouldn't even think about otherwise. So going back to education, well, this is important with regards to how medical trainees are being educated, but then also I think you were mentioning a big factor at the root of it is communicating the relevant information to patients so they know what their options are, so they understand the different considerations or can make an informed decision regarding their health. So I did a little bit of looking, and I found that most provinces and territories in Canada have a provincial official website produced by the health authority with information on contraception, although New Brunswick, Newfoundland, and Labrador and the Yukon Territory don't have that website. Often there's also lack of information regarding where to obtain the contraceptives and cost. And also a big thing is language. So these websites are mostly in English or English and French. And so it seems like there's big gaps between provinces in terms of what information is even accessible online. I was wondering if you could comment on that.
Yeah, so to address some of the decentralized access, where it's very much regional based, the Society of Obstetricians and Gynecologists in Canada actually have our own website to talk about all things sexuality in terms of contraception available in Canada. Some most frequently asked questions, the differences, the reliability differences as well. And they also address a lot of sexuality questions about HPV testing, STI prevention, PAP testing, emergency contraception. So the website is called SexandU, so SEXANDU, the letter .ca, because we're very original, that addresses all-encompassing question of sexuality and what it involves. And it is the one that I point most patients to. And there's a tablet that's just called Contraception, and you just click on it and it gives you all the options available. And it actually has a little quiz that you walk through and that you answer, and it will spit out, these are the most ones that'll probably fit your life, right? Your situation. And they actually have resources in French and in English. They have discussions about consent, LGBTQ, etc. So that is the one I send everybody to if they're uncertain or they're unfamiliar, or even educate the regional family practice physicians. Hey, send everybody to this and they have questions, etc.
That's great. Thank you so much for sharing. It sounds like a really good resource. I'll put that resource in the podcast description, as well as the map resource I was mentioning earlier. So I'd love to talk a little bit about special considerations. I'm really interested to hear more about these nuances you've been mentioning and other things we might want to consider that are not necessarily in the front of our mind. So one of them I was curious about is, how do you deal with prescribing contraception to, let's say, a youth who's hoping to access, let's say, the oral contraceptive pill, and is concerned about confidentiality if they would share a family health plan with their parents and then they would see their prescription? Or have you dealt with any cases like that?
Yeah, so as a very broad statement, each patient has their own right to privacy between themselves and their care provider, and no care provider can breach that confidentiality unless there's concerns for safety or harm to others, where there's a duty to report. So when I speak with my teenagers, my adolescents, my pediatric population who are wanting more these confidential discussions, I always tell them, I cannot tell anybody unless you give me explicit permission to do so, that I can tell your parents, or I'm in fear for your safety or safety of others. So I always start all of my discussions with that age group as that is. And I say, offer them the opportunity. Do you want to chat with me alone, or do you want to chat with your parents present? And if the child who is deemed competent, able to have their own capacity and make their own decisions, is deemed to meet that, then I give them that right of privacy. And I ask the patients, please step out and we'll complete this interview as a whole. So that is what our duty as physicians is, to encourage and promote privacy and confidentiality to our patients, and that extends to all ages. In terms of special considerations, there are certain things that we do in our practice that are different. So, for example, a parent cannot call me and ask me what happened to the patient, right, without explicit consent. Or if I'm on the phone, it's a phone conversation between myself, a patient, and their parents, then the patient has to be present, because I can't talk to the parent about the patient without explicit consent. In terms of accessing birth control in of itself, that becomes a little bit more tricky, right? Teenagers, grade schoolers, they don't have access to a car. They can't drive themselves to the pharmacist, right? They may not have the money needed to pay the dispensing fee, even though in Ontario the prescription is free. And the few dollars that we may consider for dispensing fee can be quite a bit for certain patients, right? So even when they are free, then getting to the pharmacy and getting that prescription may not be, and may be challenging. And also ensuring privacy of the pharmacist as well, right? The pharmacist also has that obligation for confidentiality. In terms of the other population that kind of falls in line with this are those who are religious minorities, and I've seen this quite a bit, and which I earlier discussed safety, right? How safe is it for you to have a contraceptive method that does not require other patients to know, right? Is there a way for you to take contraception reliably and ensure your own personal safety? So those are all discussions I have, and that the root of all of that is going to be ensuring that patients are comfortable and knowing that they have that privacy and security of the information that they divulge to you.
Right. So how do you navigate those conversations regarding safety with having a contraceptive option and maybe having pills at home or whatever it may be? Yeah, how does that go?
Well, usually it involves the question of how important is it for you to not be pregnant? What will you do in case you were to get pregnant? And is there anything that basically asking for the patient's own principles and their own ensuring that they have their own autonomy? Are you making this decision for yourself? Is there anybody coercing you? Right? Are you making this decision of your own volition? Right. So if there is ever concerns about that, having that frank and open questioning, albeit it can be very startling and hard to have, I think it is important, and it has to be brought back to, hey, I'm asking you these questions because I need to know you're safe and I want to ensure your safety, not just now when you're sitting here, but when you leave as well. So making sure the patient understand why you're asking these questions and the rationale for them, and that they are ultimately, you are trying to be providing benevolence and care for them, and that's quite important when addressing safety issues. And in some stances, it's harder than others, and you have to be very firm when dealing with those situations that, hey, you are my patient, this is why we're doing this, and this is ultimately your decision.
Right. Sounds like there's quite an art to it, and it's definitely something that you'd get better at with time. And do you find your style with regards to these conversations shifting over time, or do you feel pretty confident in the way that you address this now?
I think it's still uncomfortable. It gets easier with time and experience, but it's still not an easy discussion, especially around safety and such. And I think for me, it's not more so the conversation, but the recognition of that this is an
Mm,
issue, right? And because again, those subtleties and nuances are something you pick up with experience and with your education and being aware of them. That it's not always easily presentable. So recognizing when to have these discussions, I think for me was more important than, hey, how to have them, um,
right.
because you might miss an opportunity when you don't actually recognize it, and how you execute. Well, that's that you have practice that eventually.
Yeah, of course. I was wondering, this is a bit of an aside. Do you think there's a major or minor role for the online prescription? I've seen some companies who do or advertise that you can get a prescription for contraception online delivered to your door. I was wondering if you could comment on that.
I have yet to encounter that, but I think from a health equity and equality standpoint, I think having more access is better.
Hmm.
Because of the consequences that comes with unwanted pregnancies. So I think more access is better as long as patient safety is ultimately at the background, where we're ensuring that there is no contraindication to use. We're ensuring patients are educated about how to use it. And ensuring patients are understanding the risks and benefits of the chosen method that they have, right? With that being said, if we are able to ensure safety and ability of the patient to comply, then more access is better in terms from a public health standpoint, right? And also from a patient standpoint. I don't know where this will lead to in the future. Telemedicine is here. Telemedicine will continue to have a role in the way patients access care. And I certainly have prescribed medication just by having conversations with patients, right? But that is after close scrutiny of the patient situation and ensuring that their safety and ability to adhere to certain medications are met.
Right, of course.
So
So
that's my long-winded way of saying I really don't know where it's going to go, but I think, having more access is always better.
yeah. So I've seen that one of the ways we're increasing access is there's been an expanded scope of practice for other healthcare professionals. So now the pharmacists can also prescribe. Can the pharmacist prescribe contraceptive methods all across Canada now? Do you know where we're at there?
I think it's quite regional, depending because each allied health have their own provincial bodies. So this is where having a national college for physicians, for nurse practitioners, for pharmacists would truly benefit all of us, because then we have a national standard to which we are able to increase access, right? So in terms of having pharmacists prescribe medications, that has been available for a while now. I think it will eventually be a rollout for all provinces. I do not know what the rates are across various territories and provinces in Canada, but I think that is the general direction to where we're going, mostly because of lack of access to primary care.
Right, yeah. So aside from expanding scope of practice, what do you think we can do individually as healthcare providers first in order to improve access to contraception in our own practice? Is there anything we can do with patients, or where can we put pressure or regarding policy changes, or is there anything you'd recommend that we do that could make a difference?
So from an individual practice, I think having open conversation, good communication, and a respectful relationship with your patient is kind of at the forefront of how we provide care, and that also involves making sure that the contraception is always going to be a point of discussion for every individual, right? Most likely because I'm an OBGYN, I always ask the question, what are you using for contraception currently, right? And that's not something that every primary care provider asks, but I think it's important to ask, especially for anybody who is, in my mind, at risk of becoming pregnant. Hey, what are you using for contraception? Because that impacts the patient on so many levels, on their emotional well-being, on their physical well-being, on their social economic well-being, right? So that question should be one of the first questions to ask anybody who are at risk of becoming pregnant. In terms of policy-wise, I think that's just for us to better push the government into recognizing the data that's already been present, right? The BC has successfully lobbied for this, right? Ontario has some success, albeit with an age cutoff. Nova Scotia, they're actively lobbying the government to have it expanded as universal access. And I think recognizing us as primary care providers, how important this is and how much it changes an individual's life, hopefully opens our eyes for us to recognize, hey, it impacts our patients individually. How much does it impact our cities, our provinces, our country as a whole, right? Mm-hmm. So recognizing the importance of it, and also some of the consequences of not addressing this, hopefully will push us as physicians to better advocate for our patients.
Right. So it sounds like the impact definitely stretches beyond the individual. It impacts our communities, it impacts our provinces, our country even. So yeah, I was also curious if there's anything we should avoid doing, any big mistakes that either you've made or you'd recommend we try avoiding, or anything like that.
I think I made a lot of mistakes in my medical school training, but I think one of the ones I'm realizing is to not, I think that's a tricky question because there's a lot, but I think the biggest one is ensuring patients know what their right to consent is, right?
Mm.
Consent to start medication and also consent to stop. And it is within and recognizing that patient autonomy, and that's what it boils down to. Contraception is all about patient autonomy to their own body and to their own mind and their own free will and decision making. And this is what contraception is. Contraception grants an individual who, through history, through time, has been marginalized and put in the back burner, that step towards equality and equity in terms of self-determination, right? And that's what contraception is. It's about autonomy, and that autonomy can also allow them to stop it. Right. And a lot of patients that I see are afraid of, okay, what happens? I like it. My family doctor just kept pushing me to start it. My family doctor wouldn't take out my IUD, even though I told him I didn't want it. Well, why not? Right? Why not? You have the autonomy to start it. You have the autonomy to stop it. And that autonomy falls both ways, right? To start and stop. And I think ultimately, as a learner, recognizing how important that is and why this conversation and why I'm so passionate about is that ultimately contraception leads to more autonomy for patients.
Yeah, amazing. Thank you so much. So it's so much more than just providing a prescription and sending patients on their way, obviously. There's so many factors at play, and we've talked about a lot today. I'm sure we could talk about more. I was wondering, though, if you have a key takeaway that you'd like to share, maybe a tip for future physicians.
I think I just gave away my big thing, my ending point. But for your level, I think from a more personal journey, and for your listeners, is that don't keep your mind open when it comes to medicine. What you went into is not ultimately what you may end up with. Just like my journey into this field, right? So keep your mind open. You have a lot to learn from your patients, and understanding, it sounds cheesy, they always say it in medical school, the patient is more than that person sitting in front of you. That truly does mean a lot as well, right? And recognizing that one decision extends beyond that and has far-reaching consequences is important. So from both the training perspective and from a future practice perspective, those are my two biggest tips.
Awesome. Thank you so much for sharing everything today. And I think we all need to get talking about this more. There's so much there, and there's so many things that need to be addressed. So I really appreciate it.
Yeah, no problem at all. You have a good evening.
Thanks, you too. Thanks for tuning into Just Medicine today. I really hope you enjoyed the episode, and be sure to keep your eyes and ears peeled as we've got a lot of other exciting episodes on the way. Until next time.